You are in the ER, and a nurse hands you a lab slip, potassium 7.2. You rush to the room, expecting a code, but the patient is sitting up, eating a sandwich, and asking when they can go home. Do you panic and push calcium? Do you assume the lab is wrong? Or do you have a systematic approach that tells you exactly what to do in the next 60 seconds? Hyperkalemia is the silent killer, because the first symptom is often a flatline. Today, we aren't just reading a flowchart. We are building a mental firewall so you never miss a life-threatening step.
Hello everyone, I'm Dr. Matthew.
And I'm Dr. X. Welcome back to the channel. We are going to dissect this specific hyperkalemia algorithm you see on your screen. This is your battle plan. We will move from the terrifying acute management to the detective work of diagnosis. Let's not waste a second.
Step 1 begins right at the center with the core question. Phase 1. Is it life-threatening? Dr. X. This green box is the fork in the road between a regular clinic visit and a code blue.
Exactly. Before you even look at the patient's history, look at the red branch on the left. Does the patient have signs of severe hyperkalemia or EKG changes? This is non-negotiable. Severe isn't just a number, it's a physiological state. You are looking for muscle weakness, palpitations, or that ominous ECG. And Matthew, what's the classic EKG progression? It goes from peak T waves to PR prolongation, lost P waves, QRS widening, and finally, the sine wave. If the answer is yes, we immediately follow the arrow to call for help, code CART, cardiac monitor. Do not be a hero, get backup.
Now we are in the action zone. Let's zoom in on the red box. Protect the heart. For information, calcium gluconate 10% 10 ml IV over 2 to 3 minutes. Dr. X. A huge clinical pitfall here is the type of calcium.
Massive pitfall. The chart says calcium gluconate because it's safer for peripheral veins. But if you have a central line and the patient is crashing, use calcium chloride. Chloride has 3 times the bioavailability of elemental calcium compared to gluconate. But never put chloride in a peripheral line unless you want to cause skin necrosis. And remember, calcium does nothing to lower potassium levels. Nothing. It effectively buys you 30 to 60 minutes of membrane stability so the potassium doesn't stop the heart.
Once the heart is shielded, we move to the next box, shift K into cells. This is the standard cocktail. But I've seen residents order this and walk away.
That is malpractice. Insulin works for 4 to 6 hours. The D50 wears off in 1. You must check a fingerstick glucose 1 hour after administration. Hypoglycemia is the most common complication of hyperkalemia treatment. Also, a pro tip. If their blood sugar is already greater than 250 milligrams per deciliter, just give the insulin. You don't need the D50. Next, we see albuterol nebulizer. Note the dose. This is not an asthma puff. It is 10 to 20 mg. That is 4 to 8 continuous nebulizers back to back. If you underdose this, you get tachycardia but no potassium shift.
And the final step in the emergency arm is the only one that actually solves the problem. Remove K from body. Everything else was just hiding the potassium inside cells. This step actually kicks it out. If they make urine, loop diuretics like Lasix are your friend. If they are ESRD and anuric, call nephrology for emergent dialysis immediately.
Now, let's take a breath. The patient is stable, the EKG is normal, or you've stabilized them. We move to the right side of the chart. Step 2. Phase 2. Is it pseudo?
This addresses the patient eating the sandwich. We look at the top branch. Is the sample hemolyzed? This is incredibly common. A difficult blood draw creates pseudohyperkalemia because red blood cells burst and release intracellular K.
If the lab says hemolyzed, you see the instruction, repeat stat K level. But here is the trick. Do not wait for the repeat lab to get the EKG. If the EKG is abnormal, assume the K is real, even if the lab says hemolyzed. Hemolysis can mask a true hyperkalemia. However, if the repeat comes back normal, you're done. If the repeat confirms high K, we move to step 3, the diagnostic workup.
This brings us to the green oval, transtubular potassium gradient. Now, I know TTKG is technically an older calculation that has fallen out of favor in some academic circles due to urea recycling issues, but physiologically, it is the perfect way to understand why K is high. It asks, is the kidney trying to secrete K?
Precisely, it classifies the kidney's response. Let's look at the bottom branch first, TTKG less than 7. This is a low gradient. It means the body is screaming, high potassium. But the kidney is ignoring the call. The chart calls this, low aldosterone effect. The next question is critical. Does the patient respond to 9-alpha-fludrocortisone? Fludrocortisone is synthetic aldosterone.
If the answer is yes, meaning giving aldosterone fixes the problem, we follow the line to hyporeninemic hypoaldosteronism. This is your bread and butter medicine ward patient.
Absolutely. This is the diabetic kidney. These patients have low renin and low aldosterone. But wait, look at your medication list. ACE inhibitors, ARBs, NSAIDs, and heparin all cause this picture. You cure this patient by stopping their lisinopril or ibuprofen.
But if the answer is no, if they don't respond to fludrocortisone, it means the kidney is resistant. The aldosterone is knocking, but the kidney isn't opening the door. This leads to distal renal tubular acidosis.
This is where we find obstructive uropathy, like a big prostate blocking flow, or sickle cell disease. Also, look for K-sparing diuretics here like spironolactone or amiloride that directly block the channel.
Now let's switch gears to step 4. The top branch where TTKG greater than 7. This means the kidney is working perfectly. It is dumping potassium as fast as it can, but the level is still high. This implies the problem is coming from outside the kidney.
Correct. We follow the arrow to transcellular shift. The potassium is leaking out of the body's own cells. The first culprit listed is DKA. In DKA, the lack of insulin means cells can't hold onto potassium. A massive pearl here. A DKA patient with a normal potassium of 4.5 is actually deeply totally body potassium depleted. Once you start insulin, K will crash.
The chart also lists hyperglycemia and tissue breakdown.
In rhabdomyolysis, the muscle cells explode. Not only do you get hyperkalemia, but you get hyperphosphatemia and hypocalcemia. It's a triad. If you see high K and low calcium in a trauma patient, think rhabdo immediately.
Finally, there is the small branch, high intake.
This is the salt substitute branch. It is actually very hard to get hyperkalemic just from diet if your GFR is normal. You have to eat like 50 bananas. But in patients with CKD, switching to a potassium-based salt substitute can tip them over the edge.
Dr. X, before we close, let's look at the far right under phase 3 management again. We see cation exchange resins. Where do these fit in?
These are for the tomorrow problem, not the right now problem. K-exalate is old school, and frankly, we hate it because of the risk of bowel necrosis. Avoid it in post-op ileus patients. Podiromer and ZS9 are the new standards. They are great for keeping heart failure patients on their ACE inhibitors long-term, but they take hours to work. Never rely on them during a code.
This chart really turns a panic situation into a checklist.
That is the power of algorithms. You stabilize the membrane, you hide the K, you remove the K, and then you ask, why? If you follow this flow, you will save kidneys, and more importantly, you will save lives.
Thank you for watching. If you want this chart, check the description below.
And if you learned just one clinical pearl today, maybe the calcium chloride versus gluconate tip, hit that like button. It tells YouTube this is quality medical education. Subscribe for more deep dives, and we will see you on the next rounds.